Alright, so this PowerPoint video is on pregnancy-induced hypertension and will include several topics, including preeclampsia. Let's first talk about the different categories of pregnancy-induced hypertension. So chronic hypertension is women who have high blood pressure, over 140 over 90, before pregnancy, or when it's diagnosed early in pregnancy before 20 weeks. It could also be somebody that continues to have hypertension after delivery. So these all indicate that there's a chronic problem. Whether we knew about it before the woman was pregnant, or maybe we didn't, but it was diagnosed very early, because not everybody gets the wellness checks that they should. So sometimes when a woman becomes pregnancy and goes to the provider, it may be the first time they've been in a while. So it could be diagnosed at that point. Again, they could also develop it during pregnancy, and it can persist after delivery, which would then mean that it fell into the category of chronic. Gestational hypertension is high blood pressure that develops after week 20 in pregnancy, and this time goes away after delivery. So gestational hypertension is just that. The high blood pressure came up, but then it went away. So it's abnormal, and we just monitor it and make sure it stays under control. Preeclampsia, on the other hand, is hypertension coupled with protein in the urine and some other symptoms. So this is a much different consideration because it's more than just the blood pressure, and this condition would occur after 20 weeks of pregnancy and can be very, very challenging to recognize and treat at times. So what is preeclampsia? So preeclampsia is a disease of unknown etiology, so we don't know why it happens. There is many theories that have been developed to explain why preeclampsia happens, but there's no accepted definitive answer at this time. One thing that we've considered is trophoblast invasion, placental dysfunction, immune reactions to paternal antigens, or a systemic inflammatory response. The one thing that seems to be clear in that is that immune reaction to paternal antigens, because a risk factor for developing preeclampsia is being the first baby, or the first baby with a new father. There is an increased risk of preeclampsia occurring. There is an increased risk of preeclampsia in women who are overweight or obese, as well as women with pre-existing hypertension. So lots of things that could result in preeclampsia developing. It does occur in around 3 to 7% of nulliparous women, so women in their first pregnancies, or 1 to 3% of multiparous women, so women in subsequent pregnancies, and does have many negative outcomes. Primarily the risks that we're looking at as far as outcomes are maternal mortality, preterm birth, perinatal death, or intrauterine growth restriction. So this is a big concern because of the maternal mortality risk, as well as the risk for perinatal death. So how is it diagnosed? So diagnosis is generally done when there's a new onset of hypertension and proteinuria after 20 weeks gestation. And there's some things that we're going to do. So we see this PEACE acronym on the slide. So promoting bed rest in a quiet environment, ensuring adequate protein intake. Likely there will be an antihypertensive drug administered, and then we're going to also provide some medication to prevent convulsions if it's gone into a severe state. The development of seizures means that it's now moved from preeclampsia to eclampsia. So eclampsia is preeclampsia plus seizures. And then evaluating many physical parameters. So blood pressure, urine output, respirations, and the patellar reflex. And we're going to talk about those on the next slide, or in the next couple slides. The other thing that can happen is HELP syndrome. So HELP syndrome can occur from somebody who had preeclampsia, but can also occur on its own. And HELP syndrome is when things go a little bit further, and the mom becomes very, very sick while she's pregnant. And this can result in hemolysis of the red blood cells, elevated liver enzymes, and low platelets. A woman with preeclampsia can often have some elevated liver enzymes as it gets to be severe. And as it gets to be severe, then we worry more about developing into HELP syndrome. labs and other care during preeclampsia. So how do we differentiate? So mild preeclampsia versus severe preeclampsia are treated just a little bit differently because one has become more significant and much more concerning as far as risk factors for the mother and the infant. So mild preeclampsia would be a blood pressure that's greater than 140/90, and this is monitored on 2 occasions, at least 6 hours apart, to identify that that blood pressure is consistently elevated. And then the proteinuria would be demonstrated by a 1+ or 2+ on the dipstick that's done commonly in the doctor's office at each visit. We also would look at not just that one dip in time for the urine, but often collect a 24-hour urine to really look at what is the total amount of protein in the urine over that 24-hour period. And that's really the gold standard of diagnosis, coupled with the blood pressure, is that 24-hour urine. And anything greater than 300 milligrams would be diagnostic of mild preeclampsia. Mild preeclampsia with just these 2 symptoms and no other symptoms going on can be monitored by outpatient, but again requires significant patient education on what symptoms would be indicating that things are progressing into a worsening state and would require additional monitoring. Some of the things we might do from a nursing perspective is to monitor the vital signs. We're going to monitor for fetal movement, likely doing non-stress tests to look at how the fetus is tolerating, a biophysical profile to look at those other components, checking for fetal lung maturity, and then also some lab work would be common as well. Severe preeclampsia, on the other hand, has an even higher blood pressure, so now 160/110. Proteinuria is much higher, 3+ or greater, and that would need to be measured on 2 different dips 4 hours apart. And if we did the 24-hour urine, we would see that it would be greater than 5,000 milligrams of protein in a 24-hour urine in severe preeclampsia. So much more significant symptoms going on. In addition to those, because of those things that are going on, it's also progressed. There's going to be some oliguria, or decreased urine production, which kind of results in some increase in water retention as well. Visual disturbances like floaters or seeing spots. Elevated ALT and AST at least 2 times normal, so remember those are those liver enzymes. And then thrombocytopenia, so a decrease in that platelet count. So we're going to see some of those things you might see with HELP, but we haven't gotten to that hemolysis part yet. So severe preeclampsia is really close to heading into a much more significant, but is very significant by itself. So how do we monitor, or what do we do for severe preeclampsia? These are the women that are going to be on bed rest in the hospital for sure. Monitoring vital signs very closely, looking at fetal growth because that placenta is not functioning very well now. Monitoring for reflexes and clonus because there's going to be some hyper-reflexive state and some clonus present likely in severe preeclampsia. Offering anticonvulsants like magnesium sulfate to reduce that risk of seizures, and it will also reduce those reflexes as well. Offering corticosteroids, and those could be in a couple different forms. Those are given IM to mom, and those are given to help to prepare the fetal lungs for an imminent delivery if we have time, because it'll help to mature. Doing some fluid replacement, so some IV fluids, giving antihypertensives to bring that blood pressure down, and then if the fetus is stressed, C-section or vaginal delivery, depending on how everything is looking. Other common interventions would include a urinary catheter so that the mom is not getting up and down to the bathroom, and continual fetal monitoring to check for fetal well-being. Some other symptoms. So we see that the baby might not be growing as well, the IUGR. She might have a headache as well, epigastric pain. There might be some disorientation and just a general feeling of not feeling well. Just a general cloudy feeling that something's wrong, an ominous kind of sensation. When we give magnesium, we have to think about some of the other considerations when we're giving this medication, including a decrease in blood pressure, which would be a good side effect, but it's also going to decrease that urine output. And remember, they already had oliguria, so we're concerned about, and we really want to monitor that closely. Respiratory rate decrease. If it goes too far, we may have to decrease the magnesium. And then monitoring for those reflexes. We don't want it to become too much. So again, some of these blood pressure might decrease a little bit, urine output might decrease a little bit and not be too bad. But again, if you have all of these and they continue to decrease, then some toxicity may be occurring. And we would want to stop the magnesium and administer calcium gluconate, which is the antidote for magnesium toxicity. So you see on the other side some kind of gives you just those same things, looking at what you're really monitoring for. So really monitoring closely to ensure that we're not giving too much magnesium sulfate that could create a problem for that individual. And again, we're going to talk more about these in class, and we're going to do a case study on preeclampsia as well to work on really making sure that you guys understand the significance of this disorder. Thank you for listening.